Down syndrome. So hematologic or blood-related issues is our next topic. Some of those issues are expected or maybe not concerning. For example, people with Down syndrome tend to have what's called macrocytosis, meaning their blood cells are larger. So when the blood count is done, it'll report that the cells are larger than the normal range. But people who work with people with Down syndrome enough recognize that and say that doesn't matter. That's not something that's overly concerning because we see that. It's a normal finding that we see in Down syndrome. Sometimes they'll have a higher number of red blood cells as well. That's what the polycythemia means. That can sometimes be an indication even of sleep apnea because it's almost like going to train for your marathon in Denver and you're in that lower oxygen content. Your blood cells will naturally increase to get more oxygen to your tissues. So sometimes polycythemia or more blood cells means that when the child with Down syndrome is sleeping at nighttime, their oxygen level is dropping. And it kind of like, again, being at the top of the mountain every night. And so their blood cells will rev up. But sometimes it's just a little bit higher and we're not overly worried about it. So it's something that your doctor should certainly be checking, and we'll talk about when to check that in the next slide. Leukopenia just means a lower number of white blood cells. White blood cells are what we use to fight infections. We see the kids oftentimes, normal ranges are usually between 5 and 15, and sometimes kids with Down syndrome will be in like that 3 to 5 range. Not overly concerning, especially if it's isolated by itself and none of the other blood cells are abnormal. We don't worry too much about leukopenia or low white blood cells because you really can't do anything about it, and it's really not known to cause any long-term consequence. And then babies with Down syndrome can sometimes be born with a lower platelet count. Platelets are what do our clotting and things like that. So those get checked fairly frequently in the newborn nursery if they're low, and as long as they come back to the normal level, it's again not something we get overly concerned about. And then this is the big one that people always think about when you think about Down syndrome and blood issues is, of course, oncologic things like leukemia. So there's very strange phenomena that can happen in babies with Down syndrome called, it's a big long word, transient myeloproliferative disorder. So we call that TMD because it's a lot easier to say. And this is one of those things where the babies right out of the womb have what looks like leukemia on the blood screening. But the odd thing about TMD is that even though it looks like leukemia, and it really probably is a form of leukemia, it can go away on its own. In fact, almost all the time, within several months, that resolves on its own. And we don't really understand it very well. Why are they born with it? But it tends to self-resolve. But then there is, of course, the real leukemia. We see in about 1% of people with Down syndrome, so about 1 in 100, which means that 99 out of 100 kids will never have leukemia. But still, 1 in 100 is you never want to miss that one or have a child that is that one because it is certainly difficult. But one of the things we're going to show here is that because of the way that oncologists, especially pediatric oncologists, across the country work together to find the best treatment regimens for all children, but also subsets them out to say, with kids with Down syndrome, this is the chemotherapy protocol that worked out here. Why don't you guys try it over there? And then they try it over there, and they say, yeah, it worked over here too. And then over time, they're able to develop personalized ways of managing things like leukemia much more effectively. And in people with Down syndrome, the treatment for especially what's called AML is much better tolerated and much higher cure rate than it is even in kids who don't have Down syndrome. And then an interesting phenomenon that I don't think a lot of families are aware of, because certainly it's not in medical textbooks, so doctors oftentimes aren't aware of it, but for reasons we don't fully understand, people with Down syndrome don't seem to get solid organ tumors, meaning things like liver cancer, lung cancer, brain cancers, things like that, that tumors that grow on organs don't seem to happen with any frequency in people with Down syndrome, and we don't know why. Obviously, there's something on the 21st chromosome that must be protective against that, and certainly it is something that people are looking into to try to figure out why. What is there on the 21st chromosome that you can give to somebody who doesn't have Down syndrome that might allow them to smoke their cigarettes and not get lung cancer? But it is definitely something that is an interesting phenomenon. Again, something that a lot of people, especially doctors, are not aware of. So I talked about the TMD already. The one thing to remember, if the baby does have that transient myeloproliferative disorder when they're born, they do have a higher incidence than other kids with Down syndrome for actually getting real leukemia later in life. So we do follow them closely for that potential if they had that transient myeloproliferative disorder. And then AML, which is the leukemia that we see most frequently in younger kids with Down syndrome, is very sensitive, like we were talking about, to lower dose chemotherapy, but an 80% long-term survival for AML, which you know, it still doesn't sound awesome, but at the same time, it's better than what you would say to somebody who doesn't have Down syndrome and gets AML. Their long-term survival is nowhere near 80% at this time. And then ALL, which is the other type of leukemia, unfortunately is not as well tolerated in people with Down syndrome. And so they seem to have a lot more toxicity, side effects from the chemotherapy when it comes to ALL. Thankfully, it's the one that we don't see as often in Down syndrome, but certainly something to look at. And also an 80% long-term survival, but when you compare that to the over 90% that a child without Down syndrome has with ALL, it's not as good as it could be. So yeah, those are the big leukemia types that we see in Down syndrome. Then there's something a lot less worrisome or concerning, I suppose, like iron deficiency anemia. We certainly do seem to see it more frequently in Down syndrome, and it's not really clear why. Is it because they're very texture averse, and so things like broccoli and spinach and things like that, maybe the kids don't eat it as much, or meats? A lot of the kids have a hard time chewing the meats, and so they don't get as much iron in their diet. And then there's always the concern, are they having a hard time absorbing the iron? Because that can sometimes be a sign of celiac disease. So if I see a child with Down syndrome with iron deficiency and it's not really well explained by dietary stuff, or certainly if I replace their iron with a medication, iron supplement, and it doesn't get better, then I look for something like celiac disease, because that can cause defective iron absorption in the gut. And then the difficulty also with diagnosing, we were talking about how in Down syndrome their blood cells tend to be larger. And one of the first signs that doctors look for iron deficiency is that the cells for most people with iron deficiency are too small. But if you're already starting with a larger cell, a little smaller actually puts it in the normal range, so it won't flag on the lab values when your doctors are looking at the blood count. And so it's something that you really have to be paying attention for, sometimes sending specific iron levels, like something called a ferritin level, can be helpful for the doctor to really identify iron deficiency. So that's where the guidelines came out of. So the CBC at birth is looking for that transient myeloproliferative disorder that they can be born with. And then every year, they should get a screening for iron deficiency anemia. And that ferritin and CRP is another lab that you can send, can help to decide whether there really is an iron deficiency in the child. It can help to find it. So those are some labs that your doctor should be doing as part of those screenings as well. And then I always get this question, especially from families that have done some reading on the internet. Well, what about screening for leukemia? When do we do that? And the thing about leukemia, which is, unfortunate and also scary, is that you might, in fact, I've seen this, where you might check a blood count on a Friday and it's normal. And then on Tuesday, the child comes in with fever and bloody nose and those scary things that we never want to see, and they have leukemia. And so leukemia is not something where you test it and, they're good for a year. It's not like thyroid or something like that. So there really isn't what's called a screening for leukemia. I mean, if the child has symptoms, by all means, they should be checked. Their blood count should be checked. But if they're not symptomatic, the role of screening for leukemia really isn't there, because it's something that develops very rapidly and may not be there even a few days earlier. Okay, so immunologic issues is our next topic. So our immune system is in general, not well understood in general for all people, but also in Down syndrome, it's really not well understood, because on the one hand, they seem to have some immune deficiencies. They get those colds more frequently, they hold on to them longer, all those things we were talking about when we were talking about the ear, nose, and throat and pulmonary things. But there also are lab differences in people with Down syndrome. They tend to have, we have different types of immune antibodies in our body. One of them is called IgA. They tend to be lower in people with Down syndrome, and that can increase the risk of sinus infections and pulmonary infections. They also have lower what's called IgG, which is another type of antibody. Specifically, some of those, there's many different types of IgG, but some of those subclasses will be lower in people with Down syndrome. And again, we don't know exactly what that means, but it's certainly something that we are aware exists. And then, so while they have those underactivities of the immune system, they also have overactivity of their immune system with all types of autoimmune conditions. You name an autoimmune issue, a body fighting itself, and it happens more frequently in Down syndrome. And nobody really understands why. Hashimoto was the autoimmune thyroid problem. Graves, like we were talking about, another thyroid problem. But celiac disease, type 1 diabetes, vitiligo, alopecia areata is hair loss. The immune system fights the hair cells and makes them fall out. Arthritis in childhood is an autoimmune condition. All kinds of issues happen more frequently in people with Down syndrome. And so while they're underactive, they're also overactive at the same time. The next topic, musculoskeletal issues. So plagiocephaly is a big long word meaning flat head. And we see this a lot in pediatrics. So back in 91, 92, the American Academy of Pediatrics said, put all the babies on the back to sleep because it prevents SIDS. And it does. We don't know why, but it does. The problem is, if you have a baby, especially a baby with Down syndrome, who maybe is going to spend more time on their back just because of the fact that it's going to take them longer maybe to develop some of those sitting up and standing and getting off the back of the head. So they're going to have a higher incidence of plagiocephaly, and because of that back to sleep, saving them from SIDS, but then causing them to have a flat head on the one side frequently. So we do referrals to our craniofacial group, the plastic surgeons generally. They'll do this helmet therapy, but there's been some really interesting data that's come out in the last few years that really questions whether that's even needed, because the head is a very it can mold itself pretty rapidly in those first months of life. And so as soon as you can, getting the kids off the back of their head, so when they're not sleeping, put them on their tummy. Tummy to play is great. It's great for development because they have to push up and lift their head, and all that truncal strength that you want the babies to get happens best when they're on their belly, when they're prone. And also it gets them off their head, off the back of their head. And so it helps with this plagiocephaly. So there's really a lot of data that's talking about maybe we don't really need to be doing these helmet therapies as much as was recommended before. I'm getting some sort of error message here now. Let me hopefully get back to this. All right. And then other orthopedic musculoskeletal issues related primarily to the hypotonia. So all of our weight eventually ends up at our ankles. And so a lot of folks with Down syndrome will have a flat foot because the arch that we have from our ligaments, that ligament is also lower in tone. And so they're going to have a flat foot when they step on it. And because of that, their ankles will kind of turn sometimes, and they'll have what's the ankle hyperpronation, which you see in that first picture there, where the child is kind of walking on the insides of their foot. So some of the things that we'll do is, especially for the younger kids, once they're walking, if they're having difficulty maintaining balance because, it's hard to walk on the insides of your foot. And also as you get older, if you try later today when you're walking, in this massive convention center, try walking on the inside of your foot. You'll see over time your knees start to hurt. Maybe your hips start to hurt, your back starts to hurt because it's not a steady, stable position. And so putting some orthotics in place, whether it be these ankle orthotics that you see in the middle picture there, or a shoe insert type of orthotic, can sometimes help to give them more stability, more endurance, being able to walk longer distances because they're walking on a more appropriate base than this eversion that sometimes happens. The other thing we see more commonly is things like patellar subluxation, so your patella is your kneecap. And so there's a ligament, big fat one, that sits over your kneecap that holds it in place. But if that ligament is hypotonic, like it might be in somebody with Down syndrome, that patella can sometimes come off and dislocate. And so it is something that we watch for. Scoliosis happens more frequently. Again, because of that lower tone, sometimes the back starts to turn, especially as they get towards that rapid growth phase right before puberty hits. Atlantoaxial instability is a big concern for a lot of folks because of the spinal cord runs down your vertebral column. And so in this picture here, you can see atlas is essentially the first vertebra in your neck. So right at the base of your skull, your neck vertebrae start there. So that's what's called C1 or atlas. The one right below it is called axis. And on the axis, there's a little finger kind of projection that sticks up called the dens. You can see in that picture. It kind of sticks up from there. So the atlas sits on top of the axis and kind of rotates. That's why we can turn our head from, rotating our head around and things like that. There's a ligament that holds those two bones together. If that ligament is lower in tone, like we've been talking about throughout this whole musculoskeletal part of it, then those bones will slide on each other. And what goes right down the middle of that is the spinal cord. And so if you have too much movement of those bones, it'll compress the spinal cord. And so if you do an X-ray on everybody with Down syndrome, up to about 30% might have an abnormality on their X-ray. But only about 1% will ever have any symptoms of atlantoaxial instability. So this came up as a real issue in that 2011 guideline addressed it is, should we really be X-raying everybody with Down syndrome if so few of them actually end up having any symptoms of atlantoaxial instability? Because X-rays are not without their own potential side effects, not just the radiation exposure of the neck, but once you get if you get an abnormal X-ray, you can't really ignore it. So then they probably get either a repeat X-ray, more radiation, or they get an MRI, which is probably going to require sedation or anesthesia. And all of these risks start coming. And then, maybe you get those images and they're like, oh, it's normal now. And then all of that tests and studies and all that stuff was putting the child under more risk than perhaps was worth. And so what happens here, I'll show you here in the picture form. So this is a normal X-ray. This child does not have atlantoaxial instability. And what you'll see in the next picture is that you see how the one on the top, I wish I had a pointer, the one on the top is kind of slid down on the one on the bottom. So that spinal cord, you can imagine, is fairly well compressed within that cavity. That's atlantoaxial instability. And if we knew that the X-ray would show this every time and not be either falsely positive or falsely negative, then we would get X-rays on everybody still. The unfortunate thing is it's just not a very good screening test. We don't have a good screening test other than exam. And so at every visit with the doctor, they should do a full neurologic exam on somebody with Down syndrome. That includes checking their strength of their lower extremities, checking their reflexes, talking to families about trying to avoid activities that might lead to excessive neck movement. So jumping on the trampoline is a real concern for people with Down syndrome, mainly because if you jump, one, you're constantly jarring your neck. Two, you can fall off, and that's an uncontrolled fall. Three, kids don't just jump on trampolines anymore, right? I mean, I know that they lay on one lays down and everybody else jumps over them and all that stuff. And so that is going to lead to risk of an uncontrolled fall too. So things that we talk about at the visit is if we can avoid things that can cause excessive neck movement. That includes ENT type surgeries. So when they do the tonsils and the adenoids, they have to do a lot of kind of cranking of the neck in order to get to those parts to cut them out or whatever they have to do in the ENT surgery. And so we talk to our ENT docs about, hey, be careful when you do that. Sometimes they actually, the anesthesiologist can actually do nerve monitoring of the lower extremity. So if there's any change in the signal coming down the pipe down to the leg, they can notify the surgeon, say, hey, wait a minute, that's compressing something, let's stop. And so those kind of monitoring during surgery is important. We talk to families about, there is an increased risk of atlantoaxial instability if you're going to do something like, contact football, or rugby or something like that, where you're going to bang into somebody and your neck might jerk where you can't control it. But families often ask me, well, should I then not let my child do those things? And I always say to families, everything in life is a risk. And as parents, you have to kind of gauge, where's my risk level that I'm willing to take. It's so unlikely that somebody would ever have symptomatic atlantoaxial instability. And if they say, I love this game, this sport, I can't live without it, I have to do it, then you as a parent have to say, well, the risks and benefits, it's worth it for me to do that, because there's a risk to taking a car ride too. You can get in a car accident, you can have excessive neck flexion, and so there's risks in everything that we do. We just make our own choices. So I always say to families, if your child says, I really love swimming and I really love football, I'll do either, then pick swimming. It's like making it something that makes sense for your child and for your family. If they're ever symptomatic, so if they ever have neck pain, neck stiffness, arm or leg weakness, change in the way that they're walking, wider gait, or they're refusing to walk, and it's not a behavioral refusal, but they're refusing to walk, then they should get, or if they lose bowel bladder control and they had it before, then they should get a cervical spine x-ray at that time. But we don't do it routinely on everybody anymore. We talked about the helmet stuff already on plagiocephaly, so I'll skip that. So moving then on to the neurologic, about 5 to 10% of people with Down syndrome over the lifetime will have seizures. It really seems to be in two very distinct times of life. Either in that first year of life, they'll have an increased risk of seizures, what are called infantile spasms. And if it works, I'll show you the video here on the next slide. They can also, as they get really much older into adulthood, have more generalized seizure-type syndromes. But the one I think about as a pediatrician is in that first year of life, those infantile spasms. There's something called Moya disease. I'm not going to get into too much detail about it, but essentially it's the way that the arteries in the brain are formed increases the risk of stroke. Very, very rare. But if I ever have a child who's not acting right from a neurologic perspective, an MRI is something that can help to make sure that the blood vessels in their brain are not formed in a strange way. Alzheimer, much less common than previously thought. When I was a medical student, my textbook said that 100% of people with Down syndrome get Alzheimer's disease by the age of 40. And what we know now is that's not true. So probably more accurate is about 10% of people with Down syndrome at the age of 40 will have Alzheimer, 20% at about age 50, and at age 60 and above, probably closer to 30 to 40%. And so it's much less common. It's still more common than in the general population, but not as common as once thought, and certainly not as early onset as was once thought. So let me see if this will play. Sound is coming, video is not. So you see the challenge of being a doctor, right? I can't even tell what this challenge, no, I'm just kidding. Anyway, essentially what this baby was doing, I'm not going to be able to show you that slide, I guess. What that baby was doing was every 10 or 15 seconds or so, the baby was going like this. And then dropping, and then dropping. That movement in a baby is very concerning for infantile spasms. The rapid jerk of the arms and then the flopping forward of the head or the body. Those are what's called infantile spasms. So dermatologic skin issues are definitely more common in people with Down syndrome. Dry skin is almost universal. People with Down syndrome very frequently have very dry skin, sometimes little bumps even on their arms from where the shirt rubs and things like that. We see a lot of dry skin issues. And there's lots of very expensive creams that you could buy, or there's also Vaseline. And I find them both to be equally effective. The issue is that the moisture is not trapped on the skin as effectively as it is in other people. There's almost like a missing oily kind of layer that would trap moisture on the skin. So the best thing you can do is just put some Vaseline after a bath time on the kids, and it traps the moisture in and helps with that dry skin issue that we see. There's also lots and lots of very expensive stuff that is essentially petroleum-based, but they'll charge you a lot more money. Petroleum jelly-based, lots more money. You can choose to use either or. Brittle nails we see very, very frequently. It's on the toes, on the fingers. We definitely see a lot of brittle nail issues. Really nothing clinically, worrisome about that at all. It's not necessarily a fungal infection or anything. It's just the way that the nail itself is made. But we do definitely see more frequently athlete's foot. Athlete's foot is especially in these warmer climates, if you're wearing socks and shoes, that's like classic where yeast would like to grow, and that's what athlete's foot is. And so the most important thing is to look for it. I find at least in the summertime, at least 1 or 2 a week, kids will have athlete's foot, and nobody would have looked. And you just take and look between the toes, and certainly you'll see the little peeling and the redness in there. And it's so easily managed. One is you try to get them out of their socks and shoes, at least for a period of time, to allow that environment to change, so the yeast don't want to live there. And then putting on some over-the-counter topical antifungals is very helpful to remove the athlete's foot. Alopecia is that hair loss thing we were talking about. We do see that more frequently in people with Down syndrome. The treatment for it is very difficult because it tends to come and go. So you could, whenever you have something that comes and goes, you never know really what worked to make it better. Was it the steroid that they put on, the steroid cream? Was it the steroid injections, or was it just time? And so nobody really knows the best way. It tends to come and go, so lots of families eventually just say, let's just let it be and not treat it with any type of medication. But yeah, certainly something that we see more frequently. Dental issues, I'm not a dentist. I don't like going to the dentist. But definitely dental issues are more common in people with Down syndrome. The delayed first eruption of the tooth, but sometimes also missing teeth, wide-spaced teeth, sharp teeth. Those types of things we see much more commonly in people with Down syndrome. So they definitely need to see a dentist at least every 6 months, just like everybody else. But we try to start them a little bit earlier because oral sensitivities tend to be more common in people with Down syndrome. So we definitely want to get them into the dentist more frequently and earlier if we can because it gets them more used to that dental chair. And then general pediatric issues, immunize your kids in general is a good idea, but especially for kids with Down syndrome because they are so at risk for more infections because of that immune-related issues we were talking about. So giving them the immunization is better than finding out that they didn't tolerate the disease when they got it. And so definitely important. One extra immunization that the AAP recommends is what's called the Pneumovax vaccine. That's for any child with Down syndrome who's older than 2, who's had any type of cardiac or recurrent pulmonary disease. It helps to prevent pneumonia bacteria, 23 more types of pneumonia-type bacteria. And then RSV is something that in Florida you see year-round, but the rest of the country is really more seasonal. But it's a virus that if you have a baby who has any type of heart issue, they'll qualify for that RSV immunization, reduces their risk of RSV infection, which is a virus that we get in babies. There were updated Down syndrome growth charts that just came out last year. Your doctor should be using those. You can find them online very easily and bring them to your doctor's office because a lot of the electronic medical records have not been updated to the new growth charts, and they're far more accurate than the old ones, which were not based on modern data. So these are great growth charts to make sure that your pediatrician or family practitioner is using. And then we always talk about, especially with the kids as they get into the older age ranges, about abuse and sexuality, because people with Down syndrome tend to be very trusting and they see what they see on TV and maybe they try to emulate what the kids on High School Musical do or whatever it is. And so it's really important for parents to sit and talk with their kids about appropriateness in those types of social interactions with other kids and adults especially too, because unfortunately people people with Down syndrome can be targeted by predators and things like that. So important to let them know about safety and who's allowed to see what parts of their bodies and those types of things. If you don't talk about it, they don't know, and it's important to be very concrete and bring it up and talk about it. And then dietary issues. Obesity is not a common endpoint for everybody with Down syndrome. With the appropriate diet and exercise, people with Down syndrome do not have to be obese. It's more common because their ultimate height is, of course, limited by Down syndrome. But weight, as we all know, is not limited. And so it's important, though, to make sure that we use and teach them appropriate eating habits right from the start. You know, the 5-year-old who's coming to see me in clinic and the family says, hey, we're going to go to McDonald's as your reward. I mean, I get it, and we did that with my brother too. But it's not the best thing to do, especially if your child has a desire to eat healthier stuff, then reward them with broccoli, you know what I mean? Or reward them with something that is not food-based, because the more they get used to making those types of dietary choices as a 5-year-old, when they're 15 and in the school and have the vending machine to choose from, they're going to choose those unhealthy things because that's what they're used to. So making sure that we teach them healthy dietary choices. We definitely try to avoid either fad diets or diets that are unnecessarily restrictive, because we know that even gluten-free diet, if you don't have celiac, is deficient in certain vitamins and minerals, and so it can be something that you want to avoid unless your child really needs to have those parts of their diet adjusted. And we definitely counsel and talk to families about trying to, the internet is a scary place. There's lots of things out there that people tout as the latest and greatest management or treatment of this or that part of Down syndrome. And unfortunately, the only thing you can do is pay them $150 a month to get their special medicine that nobody else makes. That should be a red flag. If it's evidence-based and proven, then it's going to be out there in the literature. And if it's not, I would hesitate to start somebody on megavitamin or supplements that we don't even know many times what's in them because they're not FDA approved, so nobody's monitoring them. And you might find some surprises in there that is not what you expected. So we try definitely to avoid those things if they're not monitored carefully. Behavioral issues, oh my goodness, are so unfortunately common, but so manageable at the same time with the right approach. So ADHD certainly does happen more frequently in people with Down syndrome. There are management-related issues to that because the kids with Down syndrome tend to be very sensitive to ADHD medications, especially the stimulant ones. And so if you start at what is a typical normal dose of a stimulant for somebody else, if you use that dose in somebody with Down syndrome, it's an overdose. And so we really talk to providers about starting low and going slow when it comes to ADHD medication if it's necessary. Autism certainly is more common in people with Down syndrome. Probably around 10 to 15% could fit the diagnosis of autism. And some of the problems with diagnosis is that people who are not familiar with Down syndrome are, of course, also not familiar with a dual diagnosis of Down syndrome and autism. And so I'll have families that come in and they'll say, oh, we haven't been to the Down syndrome center in ages, and the child's 10 or 15 years old, and I'll say, has anyone talked to you about autism because, your child is not speaking yet, is socially having difficulties, and they'll say, no one ever said that to me. Do you think so? And I'll say, yeah, but everyone always told them that this was just Down syndrome, not to be worried about it. And certainly autism is something that we see more frequently. It's just hard for people to diagnose it if they're not used to seeing it. Sensory integration disorders, a lot of I know my brother and his friends do this too. When they get excited, they flap their hands, or maybe they don't like a certain tag feeling on the back of their neck, from the shirt, those types of things. We see a lot of sensory things. Thankfully, the kids seem to get better with them as they get older, but something that the OTs will often work with families on. And then the last one is my own made-up term. It's CDD, which is chronic discipline deficiency. It's oftentimes misdiagnosed as one of those other ones at the top. It's hard, I get it, and maybe I'm just an angry sibling, I don't know. But it's hard. You have your baby, and people was sick from the start with a heart condition, or maybe you just, your heart goes out to the struggles that you've seen them have in their development, things like that. And so it's a natural inclination for a lot of families to kind of say, well, they don't understand timeout, or they don't really need to respond to when I say no. And then what happens is, as the kids get a little bit older, 3, 4 years old, they start testing their limits. If the limits aren't set, then it gets to be a real hassle. And then when they're 5 or 6 and they're throwing the shoe at me or biting me in the clinic, I'll say, oh, have you tried timeout yet? And they'll say, oh, no, are we supposed to do that? And I'll say, well, you gotta do something. You gotta set the limits, because it's more than just the doctor abuse that happens to me in the clinic, but it's actually employability eventually. People with Down syndrome don't tend to outgrow their behavioral issue if it's not addressed. They tend to get worse, and they get bigger, and then all of a sudden the biting is a criminal offense and not just a cute little baby thing. So important to really set limits, be strict about them. Do the same thing you do with your other kids, with your kids with Down syndrome, because kids with Down syndrome are very smart, and they'll figure it out when they're not, or they're given more leeway than their sibling, and they'll take advantage of it, believe me. So make sure you stay up with that. Just a quick slide. We talked about the reduced incidence of solid organ tumors. Other things your doctor doesn't know about is people with Down syndrome don't get atherosclerotic disease. So their cholesterol levels can be through the roof, but they don't get those cholesterol plaques in their heart. It's again, something on the 21st chromosome. They don't get hypertension, high blood pressure. We don't know why. They don't seem to get strokes, except in those situations where we were talking about with that moya earlier. But they don't get the strokes that are related to like the clots and going to the brain. They just don't seem to get them. Cavities seem to happen less frequently in people with Down syndrome than in others. And again, very strange phenomenon. They do better with AML, the leukemia we were talking about. They get better recovery from infantile spasms, which was the seizures we were talking about. They do better in those things than the typical population. We all know as family members that the typical personality traits that we can see in so many people with Down syndrome, that I think a lot of us would like to be a lot more like those types of things that we see here on this list, being more loving, forgiving, organized, those types of things tends to be things that people with Down syndrome seem to excel at. And then intellectually even, people with Down syndrome seem to have a very impressive visual memory. It seems that, when I talk to my brother about, oh, you remember your birthday, he'll say, oh yeah, when I was 5, remember when we were at McDonald's and you were crying? And I say, no, I don't remember that. But he does. And so being able to remember that, if I take out one of his 500 CDs that he's got, and I say, what's track 2, he'll tell me without looking at it. And these types of things that, of course, I can't do, are definitely things that are ways that you can use when you're talking to your child's educators or even at home. Using those visual memory skills to help them to learn is a very effective thing to do. Helps them with reading too, because reading is all about visual. You look at the word dog; it's always dog. It always looks like that, so they can pick up sight words a lot easier than necessarily the traditional phonics way of treating. So especially early in life, teaching them sight words is a great way to start them on a path towards loving reading. And then very quickly in the final couple of minutes here, the Down Syndrome Center and why you should talk to your local hospitals about getting one started in your area if you don't already have one. This is a relatively new concept. Within the last probably 15 to 20 years, there's in terms of active Down syndrome centers that only see kids with Down syndrome, probably about 40 in the country. And most of them are pediatric based, although a few, like ours, also see adults as well. And the reason that's important is that if you have doctors and nurses and other people that all they do is see people with Down syndrome, then all of a sudden, you get really used to knowing what's expected for a 4-year-old. What should I do about this 15-year-old? Who's a good person to refer them to? Who's good with the kids that we know? Who's up to date with their specific subspecialty guidelines? And then also knowing what not to worry about. I've seen kids get sent to neurology clinic because when the birthday cake comes out, they got excited and they shake their hands. And that's so common in Down syndrome. We see that all the time, that sensory type of stuff. And it's not a seizure, yet I've seen them got EEGs and MRIs and all this stuff when it really isn't necessary. So that's a big part of the at least the medical side of things, being able to have a Down syndrome center. And I'm not going to go through these in the interest of time. But our center is one of the older ones in the country. It was created back in 1989. And we're pretty big, actually. At this point, we have 3 docs, a nurse, and our coordinator. We see about 600 patients a year between the 2 adult and pediatric clinics. And this actually was a picture from yesterday. So, this is something that we love to do. And I think there are people all throughout the country that would love to start a Down syndrome center. In fact, I talked to several of them yesterday at our medical group, how do we start one, things like that. Because I think it's very important. If there's an interest, there's definitely a need for it in the community. What we do a lot of prenatal counseling with, mothers will call our center and ask about information on Down syndrome because, OBs, even the best intentioned ones, may not have the most up-to-date information. And so they call us and we meet with them and talk to them about Down syndrome. And then, of course, after the child is born, we see them all throughout their lifespan in our medical visits. We provide resources to the obstetricians in our community. We do a lot of educating with the med students and residents and PT students and genetic counseling students and all this stuff because they're the front lines, really, when a family gets a new diagnosis. And so helping them to know how to do that correctly, I think, is a big part of what we do. This is our contact information. I'll just highlight a couple of different things on here. Our podcasts that we have are free. They're on our website. On any, really, medical, non-medical, all kinds of stuff that you'll find on that podcast that we put out for free for families out of our center. And then we also have created a blog for you to share your stories because it's important for new families to meet families who have gone through this and say, hey, I'm not alone. And I think one of the greatest things about both the podcast and the blog is there's just a worldwide impact from them, especially the blog. That's all stories that families share. So I always say every time I speak at this convention, share your story on the blog. The instructions on how to do that are on there, and you'll be impacting somebody in halfway across the world because they don't necessarily have any access to the care that we have here in America. So I'm open to any questions. That's me and my brother. That's us when we were younger, of course, and that's us a couple of years ago. So happy to answer any questions. And then, like I said, we have the Ask the Doctor sessions, one this afternoon and one tomorrow morning. Yeah. So the question is, what's the current treatment for infantile spasms? So infantile spasms are those seizures that the babies get when they're under a year of age. Typically what they use is what's called ACTH, which is kind of a hormone-based therapy that most people with infants with Down syndrome really respond better to that treatment than other kids do. So oftentimes that's where it stops, but there's other anti-seizure meds that can be used if needed to stop the infantile spasms, but usually ACTH is what works well for the babies. Yeah. Yes? That's a great question. So the question is the tonsil and adenoid enlargement a true enlargement, or is it just relative to the rest of the airway? And I think it's probably a combination of both, but probably more the fact that their airway is smaller. In fact, if a child with Down syndrome, let's say, is going in for a surgery and needs to be intubated, an anesthesiologist familiar with Down syndrome knows to use a smaller tube because their airway is smaller. And so because of that, what would probably be not so obstructive in terms of tonsils and adenoids in another child will obstruct in a child with Down syndrome because their airway is already smaller to start with. Yes, in the back. That's a great question. So the question is, what's a level of TSH that is treatable? So TSH changes, normal ranges change over the lifespan. So when a baby is first born, TSH levels can be all the way up into the 20s and 30s and be normal. And then over that first year of life, it starts to go more towards the normal range of being up to about 5.5 or so is what most people would consider a normal TSH. And then as long as the free T4, that thyroxine level that comes out of your thyroid gland is normal and your TSH is normal, there's nothing to be concerned about in terms of symptomatic hypothyroidism. I know there's definitely a lot of internet-based stuff that says that the TSH needs to be lower, but what I've seen has been a lot more in terms of over-supplementation side effects than I've seen improvement by trying to keep the TSH lower than what the pediatric normal ranges would be. Yeah? So the question was specifically to anesthesia. Just like we were talking about with the ADHD stuff, but also with anesthesia, people with Down syndrome are very sensitive to anesthetics. And you put it eloquently, you can always give more, but you can't take away, and that's exactly right when it comes to anesthesia. There is a great review article that came out within the last year that every pediatric anesthesiologist should have. It was published in Pediatric Anesthesiology, the journal, if you just type in anesthesia, pediatric anesthesia in Down syndrome, it came out in 2015. I sent it out to my entire anesthesia staff because your question of some person comes and takes the intake history, somebody else is doing the anesthesia, you want to make sure everybody is aware. And this article did a wonderful job of going through, don't give this one. If you give this one, watch for this side effect. It was really, really helpful. And so I sent it out to our whole anesthesia department. And that would be something maybe for your pediatrician, maybe your family practice doc to do the same thing for your institution as well, because they may not be aware. It is their, I think, their premier journal. Pediatric Anesthesia was the name of it. Yeah. Yeah, and low heart rate is a very common side effect to some of the pediatric anesthesia agents that they use, and so that's a real concern for, and something that the anesthesiologist should be very ready to address and be expecting and watching for it. So, yes. Yeah. So the question is about using Prozac in Down syndrome, regardless of, not for anxiety or depression, but just to help with the cognition. There is a study going on. We're not actually sure how it passed through their review board, their IRB, but where they're giving pregnant mothers, Prozac and seeing whether it affects the development of the baby. The jury is very much out. We don't know. There's so many different trials that have been tried, and we talked about all of them really yesterday in our medical conference, which was looking at all the things that have been tried up to this point. And things look great on paper in terms of theory, in terms of what happens when you give it to a mouse, But then when you translate that to a child or to anybody really with Down syndrome, we just haven't seen anything yet that has helped with the cognition and development for people with Down syndrome. It doesn't mean there's not going to be something. In fact, I was very excited to talk to some of those researchers yesterday and really see what's being tried and worked on. But for now, when it comes to things like Prozac or some of the other drugs that have been tried, we just haven't really seen anything have an impact, especially nothing without major side effects. So, all right, guys, I think that's it for time, but I'll be up here if you guys have any other questions, and of course the Ask the Doctor sessions.